This is not a generic Ebola scare story. This is a systems failure story. In May 2026, a Bundibugyo Ebola outbreak in Central Africa became a global health emergency. The danger is not only the virus itself, it is the collision between a difficult pathogen, weakened public health infrastructure, broken trust, delayed detection, and policy responses that may not match the biology of the disease. The center of gravity is Eastern Democratic Republic of the Congo, near the Uganda border. The outbreak is already operating across a hard terrain. Armed groups, disrupted access, fragile health systems, and cross-border movement. The core warning is momentum. By the time an outbreak appears as a clean line on a chart, the transmission chain may already be weeks ahead of the official response. And with Ebola, those weeks matter. Every missed contact, every delayed lab result, every community that hides the sick out of fear becomes fuel. Most people hear Ebola and imagine a single enemy. Operationally, that is a dangerous simplification. The Zaire strain has licensed vaccine tools and established therapeutics. Bundibugyo does not have the same approved medical toolbox. That means the usual playbook is weaker here. You cannot assume that stockpiles built around one Ebola species will automatically solve another. The virus is familiar enough to trigger panic, but different enough to expose the limits of preparedness. The first technical failure point is diagnosis. If the wrong assay is used, a suspected case can look clean on paper while remaining infectious in reality. That is one of the most dangerous failure modes in outbreak response. Not simply a missed case, but a falsely reassured system. The difference between a false negative and a true positive is not academic. It is the difference between sending someone back into the community and activating isolation, contact tracing, and clinical care. Contact tracing is where containment either becomes real or becomes theater. The target threshold shown here is 70%, enough exposed contacts identified and monitored to break chains of transmission. But the current reality depicted in this assessment is closer to 7%. That is not a narrow miss. That is a collapse. At that level, the outbreak is not being boxed in. It is being sampled from the edges, while most of the transmission chain continues unseen. Then biology meets politics on the ground. Foreign responders arrive. Communities already shaped by conflict and exploitation perceive intervention as coercion. Burial practices are disrupted. Isolation centers become symbols of fear. Patients flee. Health workers are threatened. And the virus benefits from the resulting silence. That is the distrust transmission cycle. In a textbook, containment is logistics. In the real world, containment is legitimacy. If people do not trust the response, they do not enter the response. The most promising medical countermeasure shown here is MBP134AF, an experimental pan-Ebola antibody cocktail. The reason it matters is simple. Bundibugyo strips away much of the confidence built around previous Ebola responses. If there is no approved vaccine and no approved strain-specific therapeutic, then experimental countermeasures become strategically important. But promising is not the same as available at scale. A laboratory advantage does not become outbreak control unless it can be manufactured, deployed, administered, and trusted. Now zoom out from the virus. Early warning networks have been weakened at exactly the moment they are needed most. Local partner networks, deployed public health expertise, and international coordination are not decorative. They are the sensors and muscle of epidemic response. When those systems are cut back, outbreaks are not prevented. They are discovered later, with fewer people in position, less local knowledge, and less room for error. That is the real cost of dismantling public health capacity. The bill arrives during the emergency. The U.S. posture has also shifted. The 2014 to 2016 model emphasized direct epidemiological intervention near the source, specialized repatriation for infected Americans, and active domestic monitoring after return. The 2026 model, as presented here, leans harder on border restrictions, offshore isolation, and passive screening. That is a profound change. It moves the center of response away from source control and toward perimeter management. But pathogens do not respect political perimeters. They exploit biological timing. The evacuation question is where policy meets individual risk. If an exposed U.S. citizen cannot return directly to specialized American biocontainment units, the system routes them through offshore quarantine or European transfer pathways. The problem is delay. For a high-consequence infection, 6 hours is not paperwork. 6 hours can be clinical deterioration, staffing confusion, transport risk, and missed intervention time. The question is not only whether a policy sounds tough, it is whether it produces faster care, better containment, and fewer secondary exposures. An offshore facility creates its own risk stack. First, medical capacity. If the site cannot provide the highest level of critical care, it becomes a holding pattern before the real treatment site. Second, local resistance. A foreign citizen-only containment unit can provoke backlash in the host country. Third, legal and political ambiguity. Denying or delaying return for citizens seeking life-saving care creates a constitutional and moral fight in the middle of a public health crisis. The policy may be designed to contain risk, but it can also relocate risk. Airport screening has a biological blind spot. Ebola can incubate for days before symptoms appear. A person can pass a thermal scanner because they are not feverish yet, then develop symptoms later, inside the United States. That does not mean screening is useless. It means screening is not containment. Temperature checks catch some visible illness. They do not catch exposure history, incubation timing, or every person in the silent window. Domestic containment depends on public cooperation, but the U.S. enters this scenario with a trust deficit left over from previous pandemic fights. Some people distrust federal health authorities, some distrust vaccines, some distrust mandates, some distrust the entire political class. So the challenge is not only whether agencies can issue instructions, the challenge is whether people will follow them. Low infrastructure plus low trust is the worst quadrant for outbreak response. This is the convergence. Biological vulnerability. Bundibugyo lacks the same approved tools as Zaire Ebola, and can evade assumptions built around previous responses. Systemic vulnerability. Early warning and response architecture has been weakened. Policy vulnerability, reactive border measures, and offshore triage may create delays while missing the incubation problem. When those three circles overlap, an outbreak becomes harder to contain than the virus alone would suggest. Here is the final warning. Ebola is deadly, but it is not the perfect pandemic virus. It is not airborne in the way influenza or measles can be. That limits its global spread. But this outbreak is a stress test. If the world struggles to contain a lethal, but relatively containable pathogen, what happens when the next threat spreads more easily, incubates longer, and arrives after the early warning architecture has already been hollowed out? The lesson is not panic. The lesson is preparedness. Detect early, test correctly, trace contacts fast, protect trust, fund the local networks, and build policies around biology, not optics.